All right. Can everyone hear me okay? Awesome. Very nice. I am so excited to start today. If you are just logging in, I have multiple live streams going on for this webinar today. It's a very special webinar because we are going to be going through some high yield content. We're going to get started in just about a minute or so. If you haven't already, feel free to open up your chat box, say hello where you are logging in from. We have people from Boston, Bangladesh, Philadelphia, lot of students joining. Excellent. And on other live stream platforms, if you all are joining, say from YouTube, feel free to say hello into the chat box. I'm so excited you all are here today. We're going to get started in just about a minute. Make sure you have your notebooks out. I'll be sending out a nice handout today as well to just go through some key concepts. Wonderful. We have Lydia from Missouri, Abshiro from Chicago, Chitra from New Jersey. All right. Well, happy Saturday. Good morning, good evening, good afternoon, good night, wherever you are joining. I am so excited to go ahead and get started. So if you are ready to go ahead and type in yes into the chat box. Everybody good? All right, great, wonderful. So today is a very unique and special webinar. If you are going to be preparing for Step 2 CK or SHELF, whether it's PED, surgery, OB, etc., you are going to be seeing urine studies as well as CSF analyses. And what we are going to do today is learn how to interpret these various diagnostics. For many of you, this may be your first time watching one of my videos, or you have joined many of my webinars beginning from step 1. I just want to welcome you all back. And if you have not yet met me, my name is Rahul. I am a practicing pediatric critical care physician. I also am pursuing my master's in medical education right now, and I have developed a particular interest in helping students just like you prepare for and excel on the USMLE Step 1 and Step 2 CK. And my job here today is not just to prepare you for these exams, but my hope is that I prepare you for residency and beyond. One of the unique things that makes HyGuru such a invaluable resource, and I've just been so grateful to have quite the community that I've developed throughout the past 7 years, is that I focus a lot on active recall and vignette-focused learning. My goal, especially for Step 2 CK and SHELF, is to really put in and integrate the principles of clinical reasoning. I like to draw connections. And today we're going to even go back to basic sciences. We're going to be talking about how antibiotics work. We're going to be talking about things like action potentials. So tons of integrations. Furthermore, I really like to focus on a strategic approach to test taking. You're going to be understanding how questions are written and how you can leverage that knowledge to get answers correct, whether you're practicing in UWorld or you are in the Prometric Exam Center. And then finally, I hope that my positive energy is emanating to your camera right now, but I focus a lot on making sure you stay inspired throughout the whole journey, because it is quite the grind. And the key here is to stay emotionally, physically, mentally, spiritually well throughout the whole process. So what's the triad that I like to look at? Well, there are many triads, hemolytic uremic syndrome, etc. But my USMLE triad is going to be focused on content integration, clinical reasoning, making sure that you are productive when it comes to UWorld question review, scheduling your exams, etc. And then finally, making sure that you have a peak performance mindset. Most importantly, and we have over 200 people joining us today, HyGuru has just become an absolute family. We are a lifelong community of learners in medicine, and I can't wait to prepare with you today. Here are some of the student success stories. I am so excited. Many of these students who I have prepared with for the last year or so have actually matched into residency. So kudos to all of them and their next endeavors, and wishing them all the best. I do have a special announcement. I have just added some unique sections to my Step 2 CK Rapid Review course. If you have not yet joined that course, or you're looking for a course that can help you for shelf preparation or something to just synthesize everything in a vignette-based manner, say that you're in dedicated study, I would highly recommend you to consider looking at this course. I am going to be releasing the surgery shelf review with the mapped question IDs into the Step 2 CK Rapid Review course in the coming 3 days. I'm just finishing up the editing process, and that's 10 hours of high-yield vignette-based surgery content, perfect for shelf, comp, CBSE, USMLE, etc. And just today, this morning, I added risk factors. It's 2 hours of high-yield vignette-based content, all of the risk factors that you need to know, because many of the stems on Step 2 CK and shelf are either what's the likely diagnosis, what's the next best step in management, and what is the most likely risk factor. And I wanted to make sure that I synthesize all of the key diagnoses and the most likely risk factor in this set of videos. So if you have not joined yet, I encourage you to join many of the students who are already in the Step 2 CK webinar and the course. You will also get access complimentary to the surgery shelf review. You'll get a notification when that is dropped into your account. But first, I think many of you are looking forward to this. We're going to get started with our NBME lab sheet breakdown covering CSF and urine studies. Before I get started, I do want to give you all a brief disclaimer. I asked for about an hour and 15 minutes of your time this morning. Please make sure that you take your phone and you put it on do not disturb, turn it off, make sure you take out any distractions, any sort of background things you are doing. Try to just channel your focus here, because I promise you that this 1 hour will be a game changer when it comes to your confidence and your skills in interpreting particularly CSF and urine studies. Are you guys ready to get started? Go ahead and type in yes into the chat box. Wonderful. Many people are ready to get started. That is excellent. Great. So let's go ahead and get started with our introduction. So many of you know that diagnostics are going to be in the vignette right at the lab section. Remember that every single vignette, whether it's UWorld or NBME, you're going to have the following building blocks that make up a vignette. You're going to start with the stem. And remember, for Step 2 CK, what's the likely diagnosis? What's the next best step in management? Or what is the most likely risk factor? And then you'll start with the chief complaint, go through the patient's history, medication, social history, family history, and then acutely, you will go more into the objective: vital signs, physical exam, and then labs. And within the labs, you're going to see the urine studies and the CSF studies. Finally, the vignette is going to give you some imaging, and then you'll go back to the stem. And at that time, I would encourage you to predict the answer. What do you think is the working diagnosis or the working pathophysiologic mechanism? Make sure you predict the answers before you go into the answer choices, so you avoid plugging in an answer choice into the vignette and waste time by rereading vignettes trying to be 110% accurate. Prediction means that you're going to play offense when you're going into a UWorld block or NBME CMS form. When you are using the answer choices and then plugging them back in to see if they sound correct, that is going to waste a lot of time, cause you to fall into many traps, such as your own personal biases, and you're going to get unsure and waver between 50-50. So I would encourage you, as you are practicing, to be very mindful about predicting the answer, because that really is going to elevate your scores, your knowledge, both question review and content review. So speaking of that, one of the test taking strategies that I really emphasize is after the physical exam, you want to understand what is the working diagnosis. When you are going through the vignette, and let's say that the patient has chest pain and atherosclerotic risk factors, you're going to be thinking of acute coronary syndrome as one of your working diagnoses. Well, what lab then would you want to see first? Go ahead and type into the chat. What lab would you want to see in a patient who you are suspecting up until here has acute coronary syndrome? Excellent. And I want everybody to open up their chat box and make sure that they are participating. And if you're saying troponin, you're absolutely correct. You're not going to do something random like look at a chloride level, etc. And that's one of the strategies is before you go into the labs, you have to get a working diagnosis and then lean in to the low-hanging fruit. So I'm going to re-emphasize this specific test taking strategy. And that is when you are going to be going through the vignette and in particular the lab section, avoid going from top to bottom. Many of us have this habit of starting from the top, opening up the normal lab values and trying to correlate back and forth, back and forth, back and forth, back and forth, and then bam, trying to highlight which one's abnormal. And then as soon as you highlight your abnormals, then you're going to say, whew, now I can think. And you go back and reread, you go back and relook at the labs, and you're trying to piece together what is the likely diagnosis or trying to activate that illness script. But if you play offense and you say, hey, after the physical exam, I need to come up with a working diagnosis, then you start with the low-hanging fruit lab. And that is the one that is going to give you the most specificity towards your working diagnosis. It may not be there, but at least you are looking, at least you're thinking very critically. And then finally, what you want to do is branch out to the other labs based on your low-hanging fruit lab. So let's go through an example to really illustrate that. Here we have a patient who has acute dysuria, urgency, hesitancy. She's a sexually active young female. What is going to be our working diagnosis here? Without looking at the rest of everything, what's your working diagnosis? Go ahead and type it into the chat. Excellent, Caroline. Ryan, very good. If you're saying UTI or acute cystitis, you're absolutely correct. And so what you may want to look at is your low-hanging fruit will be a UA. So you're going to kind of not look at anything else, and your eyes are first going to go to a UA, which shows nitrites, leukocyte esterase, mild proteinuria. And then you may branch out and say, okay, she has acute cystitis. Let me check her kidney function real quick. And so you see that the BUN to creatinine ratio is actually going to be relatively normal, and there is no signs of AKI. So that is a really good example of how going with the low-hanging fruit will help you stay very grounded and help you get through the vignette much quicker and more confident as you approach the answer choices. So many of these labs, whether you're talking about sodiums and CBCs, et cetera, are quantitative data points. And what you want to do is you want to be very deliberate in qualifying those. So I don't just say one sodium of 156. I say hypernatremia. You want to understand what is the qualitative assessment of that numerical data point. And then finally, what you want to do is you want to understand what's the end organ dysfunction. For example, if you are going to have a patient who has a creatinine of 7, you are going to say that the qualitative data point is high creatinine. The end organ dysfunction is kidney dysfunction because creatinine is going to be filtered via the glomerulus. So similarly, what we're going to do here is I'm going to give you a numerical data point. And we see that the cell count is going to be 40, which is elevated, and there are 65% neutrophils. So your qualitative interpretation is elevated cell count in the CSF with the neutrophilic predominance. That 65% tells us it's a neutrophilic predominance. What is going to be the end organ dysfunction that you may be predicting? Go ahead and type that into the chat. Excellent. Many of you are saying the end organ dysfunction is going to be, yep, go ahead and type it in, potentially bacterial meningitis. You're absolutely correct. So this type of thought process is very helpful. And I know it sounds really like rudimentary and common sense, but if you're very mindful of it, you're going to feel much more empowered. You're going to feel like you are dealing with this exam with strategy and a lens of a developing physician rather than just trying to go for buzzwords and random twitches that Anki may have imbibed in you. So the first part of this, we're going to be going through urine studies. And then the second part, we are going to be going through CSF interpretation. At this point, I just want to check in with you guys. Is everybody staying active and engaged? Go ahead and type in yes into the chat box. Wonderful. I hope everybody can hear me, see me. Excellent. All right. I'm going to go ahead and get started with our first question. A 75-year-old male presents with chronic progressive urinary urgency and frequency, frequently waking him up at night. He has a weak stream and endorses urinary hesitancy. He has no fevers. The prostate is diffusely enlarged, smooth, with no tenderness. Because he's having urinary symptoms, the first lab that I want to go to is going to be a creatinine, and we notice that he has a high creatinine. What is the next best step in evaluation? Go ahead and type that into the chat. A, prostate biopsy. B, renal biopsy. C, cystoscopy. D, renal ultrasound. Or E, urine cytology. What do you think would be the best answer here? Excellent. So a lot of varying answers. Let's go through this. Here we have an elderly patient with chronic lower urinary symptoms, as noted by the nocturia and the urinary urgency with weak stream. He also is going to have a large prostate. Because it's a chronic tempo, less likely it's going to be infection-oriented. And one of the key basic science and anatomy tie-ins that you want to know is that remember that the prostatic urethra is going to course through the urethra itself. And if you have BPH, which is benign prostatic hyperplasia, you can compress the urethral, compress the prostatic urethra and subsequently get bilateral hydronephrosis. And that is going to be best surveillanced by a renal ultrasound. Remember that this is an example of post-renal AKI. All right, very good. So in the vignette, we saw that the patient had lower urinary tract symptoms. So let's just capture what you want to be thinking of in the vignette with lower urinary tract symptoms, and that should then prompt you to get a urine analysis. Dysuria, so they're going to say burning with peeing. Frequency, they're going to be going to the bathroom very, very often, and they are going to have some incomplete voiding. They'll feel like they have to go, but nothing is going to come out. They're going to wake up more than 2 times per night to pee. They're going to have a large amount of urine. Or if something is wrong with the kidneys, for example, they may have oliguria. At some point, let's say in signs of shock, where the kidney is going to have necrosis, acute tubular necrosis, or the kidney is going to suffer really bad intrarenal damage, you may even have anuria, which means there's no urine. So polyuria, too much urine, oliguria, too little, and anuria, relatively absent. So let's qualify these symptoms in the vignette a little bit more. When it comes to dysuria, you want to be thinking of a urinary tract infection. This is just in general. There may be multiple differentials, but I'm giving you the ones that are most commonly tested. In terms of nocturia, you're going to be thinking of BPH. I also put diabetes here. One of the key vignettes from a PEDS shelf that you want to be thinking of is a child who presents with secondary enuresis. Secondary nocturnal enuresis is a child who's going to be, let's say, greater than 5, who was going to be initially potty trained, but suddenly starts having episodes of wetting the bed at night. You're going to be thinking about psychological or trauma things, but you also want to make sure that this is not a new presentation of type 1 diabetes, i.e. nocturia could be the polyuria that he might be facing at night. Speaking of polyuria, these are patients who are going to be peeing more than 3 liters per day, especially in adults. You're going to be thinking about not only diabetes mellitus, but diabetes insipidus as well. And we're going to integrate that vignette very shortly. Oliguria, you're not going to have as much urine, less than 400 mLs per day, and you're going to be thinking about the kidney. Remember, the kidney is going to filter the blood and start making urine from the glomerulus through the nephron itself. So oliguria may mean that you're not going to be perfusing the kidney as well, or the kidney itself is not working and you're not making urine. Anuria could be due to shock, or it could be due to a urinary obstruction. And we saw that this patient here had some hesitancy, had relative amount of incomplete voiding. And so I just want you to really understand this concept of urethral obstruction causing you to have urinary obstruction, or bladder outlet obstruction is another way to think about this. And remember, these patients may even have overflow incontinence. And that is extremely high yield for us to know. So in many of these lower urinary tract symptoms that you're going to be recognizing in the vignette, the next best step in management is going to be obtaining a UA. Now, the NBME and your UWorld questions may just give you the UA, and then you will transition into interpreting that lab study. So let's go ahead and go through this vignette. A 32-year-old female, G1P0, at 38 weeks gestation, presents with urinary frequency. She has sleep interruptions. There's no fever, dysuria, or hematuria. There is no CVA tenderness or suprapubic tenderness. Fundal height is 37 centimeters. UA is negative for leukocyte esterase and nitrites. What is the likely mechanism underlying her symptoms? So this is a third trimester female who frequently, while laying flat, so to say, or just being pregnant, is going to have urinary frequency. And the mechanism is actually a normal phenomena of pregnancy. If you look at the sagittal anatomy of a female, and we notice that there's a baby here, the uterus expanding can exert pressure on the bladder and reduce the bladder capacity. And that reduction in bladder capacity is why pregnant patients have to urinate very frequently. So it's local compression. Progesterone does also have a mechanism with regards to the increased frequency that pregnant patients usually have. Now, why I wrote this vignette is to really highlight another key test-taking strategy, and that is really paying attention to the words no, negative, and normal in a vignette. In this case, when you have a third trimester female, you want to be thinking of a large range of differentials if she is endorsing lower urinary tract symptoms. But I put some pertinent negatives. For example, no fever or dysuria, indicating that this is not going to be something like a UTI. No hematuria. It's not going to be like a nephritic syndrome or a kidney stone. There is no CVA tenderness or costovertebral angle tenderness, ruling out pyelonephritis. There's no suprapubic tenderness, again, ruling out acute cystitis. And the UA is going to be negative for leukocyte esterase and nitrites. So what you're really going to be activating here is the fact that this patient actually is having no real signs of urinary tract infection. And so that would move you away from an answer choice that is related to acute cystitis. Another thing that I can say is no proteinuria. If I put no proteinuria, what does that rule out? Go ahead and type that into the chat. If I put no proteinuria seen on UA in this third trimester female. Excellent. If you're saying preeclampsia, absolutely, or nephrotic syndrome, absolutely. So these are, again, pertinent negatives that are going to rule you away from certain diagnoses. So rather than skimming through them, I would say, okay, this rules out a certain diagnosis. And that's how doctors think, is when you see data that is not going to be turning up positive, or history elements that are going to be normal, then you should rule out certain thought processes. All right. So now we're going to move into interpreting the urine analysis. Now, At times, a urine analysis can involve a dipstick followed by formal microscopy and cytology. And what the urinary dipstick gives us is a urine pH, a urine specific gravity, which measures the urine density to pure water. If you have a high urine specific gravity, that means your urine is very dense or maybe even concentrated compared to pure water density. Leukocyte esterase, remember that this is going to be a normal enzymes that is made by WBCs. Nitrites, remember that gram-negative organisms are going to take nitrates and turn them into nitrites. So whenever nitrites are positive, I think of gram-negative organisms that are causing the urinary tract infection. Glucose is also going to be checked. Protein is going to be checked. Ketones, as well as blood or heme. Now, what is important for us to know is that glucose, protein, ketones, heme are usually going to be associated with the following diagnoses. Glucose in the urine, you're going to be thinking about diabetes mellitus, either type 1 or type 2. And this relates to a nice basic science concept of SPLA, where greater than 200 serum glucose concentrations, you'll start reaching your transport maximum when it comes to your renal reabsorption rate of glucose, and thus you're going to start peeing out a lot of sugar. Proteinuria, you're going to be thinking about having some sort of nephrotic syndrome. At times during dehydration, you could have mild proteinuria, and you're going to be thinking about CKD. Let's say due to long-term diabetes, you can get microscopic albuminuria that then goes into macroscopic albuminuria, and keep that thought process in mind because we are going to be covering that question very shortly. Seeing ketones in the urine, you're going to be thinking not only about maybe mild dehydration, but you're going to be thinking about diabetic ketoacidosis. And remember that patients with diabetic ketoacidosis, they are going to, on your clinical vignette, they're going to have polyuria, polydipsia, and polyphagia. And then they're going to have an anion gap metabolic acidosis with ketones both in the blood and the urine. And then finally, when you are going to see RBCs that are going to be positive within the dipstick as well as on microscopy, you're going to be thinking of many different things, but in general, nephritic syndrome, watch for casts, or some sort of kidney stone. Watch for those dysmorphic RBCs that are getting sheared as the stone is causing irritation to the ureter. And with that, I want to go through this question to apply the knowledge. All right, continue to stay active and engaged with me. An 18-year-old female presents with acute generalized tonic-clonic seizures after being found unresponsive at her school. I'm going to pause here and give you my interpretation and question breakdown. Anytime you see unresponsive teenager, you're going to be thinking of a multitude of diagnoses, but the working diagnosis in this situation should be an acute ingestion. It could also be a brain tumor, it could be primary epilepsy, an electrolyte abnormality, but working diagnosis in young teenagers who are unresponsive should be toxidromes. She has had a prodrome of abdominal pain. On arrival to the emergency department, she is noted to be febrile, hypertensive, tachycardic, and confused. Laboratory evaluation is obtained. Urine analysis is notable for, we have negative glucose, ketones that are trace, leukocyte esterase and nitrates are negative, indicating that this is not going to be a UTI, and blood that is going to be positive, 2+. The microscopy of the urine shows 2 to 4 white blood cells per high-powered field and 0 to 1 red blood cells per high-powered field. Go ahead and type into the chat, which of the following best explains the patient's diagnostic abnormalities? A, rhabdo, B, glomerulonephritis, C, nephrolithiasis, D, UTI, or E, acute interstitial nephritis. Wonderful. If you are saying A, rhabdomyolysis, you are absolutely correct. Now, the important part here is for us to know that whenever you see a vignette that is on the dipstick going to be positive for heme or blood, and on the microscopy, you don't see any red blood cells, you want to be thinking about rhabdo. And one of the key things for us to conceptualize here is that the dipstick is unable to differentiate between hemoglobin and myoglobin. And so as a result, you'll get positive dipstick RBC or blood with a negative RBCs on microscopy. One of the things that I would highly recommend you to do is take a certain diagnosis and ask yourself the 4 W's. This helps me when I am trying to conceptualize various diagnoses that I'm going to see on shelf and step 2 CK. So what are the 4 W's? When is this pathology occurring? i.e., what's the tempo of the pathology? Who does it affect? What are the history factors in the vignette? Why does it occur? You may want to put a star right here. And the reason why is because if you understand the why, i.e., the pathophysiology behind the diagnosis, you're going to really be able to derive historical elements, tempo, and the what, which is going to be more of your diagnostics and the objective findings that you're going to see on physical exam, labs, and imaging. So for rhabdomyolysis, it is a relatively acute pathology, and you want to be thinking of a certain trigger. In this case, the seizures was the trigger towards the downstream rhabdomyolysis. Another one could be a crush injury or an elderly patient that is found down. Now, medications can also cause rhabdomyolysis. Things like statins or fibrates notoriously can cause you to have rhabdo. Now, the why is extremely important. This is going to be a pathology where you have direct or indirect insult that causes a damage to the muscle, and the muscle then releases myoglobin. And I think that this is such an important point for me to emphasize. Chapters 1 through 3 of Pathoma, yet again, is going to show up here. And that is that concept of cell injury, death, and adaptations. Remember that membrane damage is going to be an irreversible marker of cellular injury. And so what we want to understand is that when you have membrane damage, enzymes are going to leak. In this case, if the muscle is going to be damaged, you're going to have CK that's going to be released. What about if the cardiac muscle was going to be damaged? What is going to be released? Troponin. Let's go ahead and integrate this point into the chat box. What if I ask you a hepatocyte is damaged? What is going to leak out into the serum? Go ahead and type that into the chat. A hepatocyte is damaged, i.e. hepatocellular membrane damage. Wonderful. If you're going to say AST or ALT, absolutely. So understanding membrane damage is going to be very essential even on step 2 CK. Now, the what when it comes to rhabdo is going to be a very high CK level, a dipstick that is going to be positive for blood, and a microscopy that is going to be negative for RBCs, like we talked about in our vignette. Going further into this concept of understanding the pathophysiology of disease, I like to also take certain pathologies and turn it into a 3-step type of framework. Now, this is something that you can even put into ChatGPT, a certain diagnosis, and say, give me 3 short bullet points that are going to explain the pathophysiology of this diagnosis in a sequential manner. So here we have muscle lysis or necrosis. That releases not only CK, but phos as well as potassium. And remember that the cell, skeletal muscle cell, is going to be very rich in ATP. So it makes sense that phos is going to be released. And the cell is also going to be very rich in intracellular potassium. So in states of the cell bursting, you're going to release a lot of potassium. What is the link here? Tumor lysis syndrome has the similar type of pathophysiology like rhabdomyolysis, except in tumor lysis syndrome, the underlying etiology is a blast crisis. Both of these pathologies actually can vector into AKI. Now, AKI is the end organ dysfunction. But if we went backwards and we say, what's the qualitative, what's the quantitative that we have to recognize on USMLE questions? The answer would be an elevated BUN/creatinine. And that's high yield for us to know. So when it comes to diagnostics and management, remember for rhabdo, you want to understand what is the underlying trigger. Maybe it's a statin, maybe they're on fibrates and statins. You want to get serial laboratory monitoring, and hydration is key. And the reason why hydration and normal saline type of fluid or even buffered bicarb containing fluids is key for rhabdomyolysis is because myoglobin is toxic to the tubular epithelium. So the more that you hydrate them above maintenance, you're going to allow them to pee out that very toxic myoglobin. All right. The next concept in the urine analysis that we're going to be talking about is the specific gravity. Now, high specific gravity versus low specific gravity. Let's go ahead and compare and contrast them. High specific gravity means that your urine is going to be very concentrated. It is going to be greater than 1030 or 1.030. The vignettes that you really want to integrate here are going to be heart failure, dehydration, and even glucosuria. Why heart failure and dehydration? Well, in these situations, the kidney is going to have low perfusion. And if the kidney is going to have low perfusion, you're going to upregulate particularly aquaporins. And those aquaporins, thanks to ADH, are going to bring in a lot of free water, and that is then going to concentrate your urine. Contrast this with low specific gravity. The urine is going to be very dilute, less than 1.005. The vignettes that you're going to be thinking of here are going to be renal failure and diabetes insipidus. Let's go through this. Diabetes insipidus is going to be where you have absent ADH either centrally or your distal collecting duct is not responding to ADH. And so you have an inability to concentrate the urine. Well, if you have an inability to bring in free water back into your body, your serum osmolarity is going to go up and your urine osmolarity is going to be low. And as a result, your specific gravity is also going to be low. So in general, a high specific gravity means that you have a high urine osmolarity, and a low specific gravity means that you have a low urine osmolarity. Another way to think about this is whether you are in the hospital or you're on a health kick. Let's go through that. When you're in the hospital, I am frequently, when I'm on my 24-hour calls, I am notorious for just drinking coffee and not drinking any water or real fluid, so to say. And so when I use the restroom, the pee is going to be dark yellow and concentrated, i.e., very high urine specific gravity. However, when I'm on my health kick and I'm going to be drinking 1 gallon of water, thinking I'm super healthy, well, in that situation, when I'm going to be peeing, it's going to be very light. It's going to be very dilute. It is going to have a low urine osmolarity or specific gravity. And so I really want to emphasize this by going to the whiteboard here. And I want to just compare and contrast two key pathologies. And that is going to be your diabetes insipidus as well as your SIADH. Remember, both of these are going to be related to the concept of ADH. And if this is the distal collecting duct, pardon my artwork, and this is going to be the blood vessel right here, you're going to be thinking of ADH normally bringing in free water from the tubular lumen into the blood. This is going to be thanks to your aquaporins. So in SIADH, which is syndrome of inappropriate ADH, you are going to bring in way too much free water. So that is too much aquaporins. And so go ahead and type into the chat, what would be your serum osmolarity if you brought in too much free water? Go ahead and type that into the chat. Would it be high or low? Exactly. Absolutely. And low serum osmolarity is basically going to mean low sodium in your blood. So I'm going to draw this as a blood vessel, low serum osmolarity, hyponatremia. Your urine osmolarity, i.e. your pee, is going to be very high. And typically they'll say greater than 100. That's going to be your high urine osmolarity. Now, for SIADH, the couple clouds of vignettes that you want to be thinking of is I think about anything brain or anything lung. So brain tumors can cause this, any traumatic brain injury, even a pneumonia can cause you to have SIADH. Whereas another key vignette is going to be a paraneoplastic syndrome. And that paraneoplastic syndrome is going to be from a lung cancer. Go ahead and type into the chat, what lung cancer is notorious for causing SIADH? Okay. Many of you are saying small cell lung carcinoma, and you're absolutely correct. So in this situation, in SIADH, the first thing that you want to do is fluid restriction. Because if you do fluid restriction, your hope is that you're going to have less free water, and thus your serum sodium is going to start to rise. However, if that doesn't work, then you go into the thought process of considering the use of Vaptans. And remember, Vaptans like tolvaptan, conivaptan, they are V2 antagonists. And so they're going to kind of plug up the aquaporins so that they are not going to continue to bring in more free water. Now, diabetes insipidus, remember that that is where you do not have any aquaporins or a decreased response. And as a result, you are unable to bring in any free water. So all that free water is going to stay in the pee. And if there's more free water in the pee and you're just polyuric and you're going to be peeing out so much dilute urine, well, guess what? Your serum osmolarity is going to rise. And if your serum osmolarity rises, your serum sodium rises. And one key physiologic integration here is that patients in your vignette are going to be hella thirsty because this triggers the osmoreceptors to, here we go. And this is coffee. I'm bad. To have the patient drink increased amounts. Now, what is important integration here is to recognize that both diabetes mellitus and diabetes insipidus are going to have polydipsia, or drinking a lot of water. In diabetes mellitus, what is driving the polydipsia is going to be a high serum glucose. Whereas in diabetes insipidus, what is driving the polydipsia is going to be high sodium. What is going to be your urine osmolarity in diabetes insipidus? Go ahead and type that into the chat. Urine osmolarity in diabetes insipidus. You got it. If you're saying low, very good. Typically, this is going to be less than 700. I wouldn't get fixated on the numbers. I like to use the vignette characteristics as well as the serum sodium to see which way am I going, as well as, remember, diabetes insipidus, a lot of urine that they are going to be peeing out. The first thing that you want to do actually to test is going to be fluid restriction. This is also called a water deprivation challenge. And then you want to see whether or not the patient is going to respond to exogenous ADH or not. And that's very important for us to note. All right. With that, we're going to go ahead and apply. Are you guys learning something? Everybody doing okay? Just go ahead and type in yes or no into the chat box. Wonderful. Great. A lot of physiology. I'm an intensivist, so I can't help myself sometimes. Very good. Well, we're going to continue on. We're almost done with the urinary studies, and then we're going to go into the CSF studies. You guys are doing absolutely phenomenal. Stay active, stay engaged. Here we go. A 55-year-old male with history of atherosclerotic risk factors presents with subacute proximal muscle weakness. He is noted to have hypertension, diffuse crackles, and 2+ lower extremity edema. So his volume status seems to be he is very hypervolemic. Here are going to be his urine and serum studies. Which of the following additional lab findings may be notable in this patient? Go ahead and just take some time, put your answer into the chat box. If you're watching this at another time, pause the video, actively recall, what do you think this is? And go ahead and unpause the video when you're ready for the explanation. All right. Great. Well, the answer here is actually going to be E, a urine sodium greater than 40. Let me go ahead and explain what this patient may be having. Well, in this case, this patient may have acute tubular necrosis. You have these granular or muddy brown casts, and you have a BUN to creatinine ratio that is 10 to 15 is to 1. Now, this is going to be conceptualized as intrarenal AKI. So, in intrarenal AKI, there are two thought processes that you're going to need to be thinking of. You're going to be unable to reabsorb sodium because your tubules suck, and you're going to be unable to concentrate your urine. So, if you are going to be unable to reabsorb your sodium, your FeNA or fractional excretion of sodium actually is going to be high. Your urine sodium is going to be high. Your specific gravity, because you are going to be unable to concentrate your urine, actually is going to be low. Remember that the urine sodium is high, not low, and this is not going to be suggestive of infection. So the best answer is going to be E. Urine sodium greater than 40 is one of the key markers for intrarenal AKI. Now, one of the other schemas that I want to emphasize here is when you get a vignette and let's say there are urinary symptoms or there are changes in urine output like oliguria, I really center myself around what does the kidney normally do and what do I need to be thinking of in terms of diagnosis and management when I get a step 2 renal question. Here we go. Kidney is going to be very important in fluid balance. So patients who have kidney dysfunction are going to be primarily hypervolemic at times. Kidney is going to be very important in electrolyte balance. So these patients are going to have, at times, a propensity to get hyperkalemia. The kidney is important in acid-base regulation. So at times, you can get a renal tubular acidosis. The kidney is also going to be very important in eliminating toxins, things like urea, things like, for example, medications that the patient may be on. So those medications may actually go up to more toxic levels. Things like tacrolimus, for example, if the patient has an AKI, that immunosuppressive can go up in very high concentrations. So these are going to be different schemas you're going to need to think about when the kidney is going to fail. And subsequently, you're going to get a UA, you're going to get a renal function panel, and you're going to be considering how do I support the kidney? And primarily, it's going to be renal protection. So if they are going to be on medications that are renally cleared, you're going to work with your pharmacist to renally adjust those medications. All right. So we have talked about intrarenal AKI, and I wanted to juxtapose the vignette of prerenal AKI in this concept. Now, in prerenal AKI, your BUN to creatinine ratio is going to be greater than 20 to 1. And so, do you get this test taking strategy now? When I see a BUN to creatinine ratio on my NBME questions, I'm going to quickly do, hey, what's the ratio so I can stratify a little bit better? Now, the urine sodium in prerenal AKI, where you do not have effective perfusion to the kidney, say due to heart failure, hypovolemia, or even renal artery stenosis, the urine sodium is going to be low. And the reason why is because you get renin-angiotensin aldosterone activation. Recall that aldosterone is going to increase the amount of ENaC channels at the collecting duct in the alpha intercalated cells, and you are going to bring in a lot more sodium from that channel. Now, your FeNA is also going to be low because your urine sodium is low, and because you are in a relatively hypovolemic or low perfusion state to the kidney, you're going to be bringing in those aquaporins to concentrate your urine and reabsorb that free water. Now, in intrarenal AKI, your BUN to creatinine ratio is going to be 10 to 15 is to 1. Your urine sodium actually is going to be greater than 20. I apologize for that. And this is going to be due to a disruption of tubular reabsorption. Remember, things like the SGLT2 channel ain't working because you have intrarenal kidney damage. Your FeNA is going to be greater than 2%, and your urine-specific gravity in general is going to be low because you lost the concentrating ability. You lost the ability for the aquaporins to insert themselves in the luminal aspect of the collecting duct. So here is going to be a very important basic science integration, and that is that whenever you see casts, think about something going wrong in the nephron. So I'll just type in here or put right in here, cast equals something going wrong in the nephron. And this is going to represent renal tubular precipitation of either protein or cellular elements, such as the tubular epithelium. This indicates when you see cast, nephron or upper urinary tract issue. Another thing for us to really keep in mind is this concept of the interstitium. Now, remember that here's the nephron. Here is going to be the peritubular capillary, where we're going to reabsorb substances or excrete substances or secrete substances. But in the middle here in pink is going to be the interstitium. And the USMLE loves for you to know that at times, the NSAIDs, penicillins, diuretics, or sulfa derivatives that you're going to see in the meds portion of your vignette, they love to kind of stay here in the interstitium and create a downstream immune response. So hold that thought right here. You have something in the renal interstitium irritating the renal interstitium, and you are going to have an immune response. Let's go ahead and go through this space repetition vignette. A 55-year-old male smoker with atherosclerotic risk factors presents with intermittent bloody urine. The patient has no pain, pertinent negative, dysuria, or urethral discharge. He denies flank pain as well. There is no CVA tenderness. A urine analysis is notable for greater than 50 red blood cells per high power field, no casts, indicating no glomerular issue, and no dysmorphic cells, again, indicating that there's not a glomerular issue. What is going to be the next best step in diagnosis in this patient? Go ahead and type that into the chat. And this is a vignette that you're going to be predicting more. And if you're saying cystoscopy, you are absolutely correct. Now, what I want you all to recognize here is if I gave you an Anki card and I said painless hematuria, you would probably activate the illness script that I'm worried about bladder cancer, for example. And what I want you guys to really understand is that it is not just about understanding the buzzwords, but it is about interpreting line by line why the test maker puts the certain symptoms or essentially pertinent positives into the vignette. And that is where my courses really excel. I really want to focus on understanding the wording of the vignette and how it relates to the content knowledge so that then you can effectively apply. So in this case, because the patient is a smoker, is going to have painless hematuria, you're going to be thinking of looking at potentially the bladder and for any mass within the bladder. So painless hematuria equals bladder cancer. And one of the nuances that is seen in some of the UWorld questions is understanding whether or not the patient is having hematuria throughout the urinary cycle or whether it's at the end of them peeing. If it's at the end of them peeing, typically you're going to associate that pathology to the bladder neck or the prostate, because at the end of micturition, you are going to have the bladder neck and the bladder muscle contract to kind of get that last little bit of urine out. So if you see clots at the end of urination, make sure that you're looking at these two areas. If it's through the entire micturition cycle from the start to the end, you're going to be thinking damage somewhere in the urinary system, whether that's kidneys, ureters, bladder, or beyond. So one of the things that we talked about was casts, and this is a USMLE Step 1 slide, but I think that it has great relevance in our discussion right now. So when you see hyaline casts, this is going to represent primarily dehydration. You can also see this in nephrotic syndrome. A red blood cell cast, you're going to be thinking about glomerulonephritis. Remember, in the vignette, many patients with glomerulonephritis have hypertension because glomerulonephritis is a shit ton of complement and a lot of RAS activation. If you see a white blood cell cast, you're going to be thinking of pyelonephritis or acute interstitial nephritis. If you see a fatty cast, you're going to be thinking of primarily nephrotic syndrome. So RBC cast, nephritic, fatty cast, you're going to think of nephrotic. And then if you see a renal tubular cast, this is also known as that muddy brown cast, you're going to be thinking of acute tubular necrosis. And you want to understand what was the insult that led to it. Was it a nephrotoxin? Was it going to be hypoperfusion or shock? So specific gravity, we talked about how if it is very concentrated, high specific gravity, if it's low, you're going to think of dilute urine. Protein, blood, leukoesterase, as well as nitrites. Some of the key things for us to know when it comes to the infectious kind of UA markers, sterile pyuria can be seen in chlamydial UTIs. Sterile pyuria can even be seen on your ped shelf in Kawasaki disease. What this basically means is that the patient does have inflammation, and that's causing WBCs to pyuria, peeing out. However, the culture is going to be negative. It's not going to show any infections. Nitrites are going to be particularly relevant for gram-negative organisms. And this is a nice USMLE vignette where you have a patient who's an elderly patient who underwent cystoscopy or colonoscopy, has a tender prostate, has maybe signs of lower urinary tract symptoms. And then they're going to say leukoesterase is positive and nitrites are negative. And the answer is going to actually be Enterococcus, because that is going to be a gram-positive organism that can frequently cause UTIs or prostatitis after some sort of genitourinary or colonic manipulation. This is going to be our last slide related to urine studies and urine analysis. Are you guys ready to get this over with? Go ahead and type in yes into the chat box. Wonderful. I have 15 to 20 more minutes for CSF, and then I will get you all out of here very much prepared. You guys are doing great. Let's keep going. So a patient presents with urinary symptoms. This is what I call essentially pivoting the vignette. And what I mean is, here's something common, urinary symptoms. We talked about it, dysuria, urgency, frequency. And then now I'm going to be pivoting. What are the different variations of the vignette? What if you see a UA notable for eosinophilia? That is your acute interstitial nephritis. Watch for that drug trigger, either penicillins or NSAIDs. What about this one? Rising creatinine and bilateral hydronephrosis. The next best step is to put a Foley in, decompress, because we're worried about some sort of distal bladder obstruction or urethral obstruction. What about this one? A child post upper respiratory tract that was there 2 weeks ago, and now afterwards is going to have RBC cast and dysmorphic red blood cells. In this situation, you're going to be thinking about post-streptococcal glomerulonephritis. Remember that IgA nephropathy is going to be a differential diagnosis, and in IgA nephropathy, the complement levels usually are going to be normal because IgA cannot fix complement, whereas in PSGN, this type 3 hypersensitivity reaction gives you low C3. Unilateral flank pain, hematuria, no real casts. Well, flank pain and hematuria, you're going to be thinking about a kidney stone. And in this situation, you want to get CT scan of the abdomen and pelvis. What else are you going to be thinking about with a flank pain and hematuria presentation? Renal cell carcinoma. And that is high yield for us to know. And remember, renal cell carcinoma can cause you to have paraneoplastic secretion of erythropoietin. So maybe the hematocrit will be very, very elevated. All right. So what if you have a patient who has hypertension, hemoglobin A1C that is very elevated chronically, and a UA that shows 2+ proteinuria? Go ahead and type into the chat What is the next best step in management to address the hypertension? And if you haven't answered just yet, I would continue to stay active here. We're almost done. You got it. This is going to be ACE inhibitor therapy. Remember that in diabetes that is long-standing and uncontrolled, you can get non-enzymatic glycosylation, and that can cause microangiopathy in the kidney, making you proliferate your mesangium. Remember the Kimmelston-Wilstein nodules, and you're going to be peeing out a lot of protein. Now, other things you want to be thinking about related to microangiopathy is these patients can even have diabetic retinopathy, which is going to be a proliferation of blood vessels in the eye. And again, that relates to the pathophysiologic mechanism of microangiopathy, high yield when it comes to diabetes. What about if you see painless hematuria with cystoscopy revealing a bladder mass? Go ahead and type into the chat, what is the most likely risk factor here? Very good. And I have this again integrated in my risk factors section of my my step 2 CK course. Very good. Sexually active female who presents with acute fever and nausea and also has positive flank tenderness. Nitrites are going to be positive. Leukosterase is going to be positive. So this is a UTI with systemic symptoms, i.e. nausea, fever. You're actually going to be thinking primarily of pyelonephritis with the systemic symptoms. And the treatment is going to be ceftriaxone. And ceftriaxone is going to be one of the mainstay treatments for acute pyelonephritis because it is going to cover E. coli. All right, very good. We're going to pivot and go through CSF interpretation. Now, I know it's been a long session thus far, but I want you to go ahead. Please do this. Take a deep breath with me. Here we go. I know some people may not have done it, so let me go ahead and do it again. All right, let's stay dialed in. CSF interpretation is coming at you next. So what we're going to be talking about is CSF interpretation, but in order for us to get the CSF, what do we need to do? We need to do a lumbar puncture. So let's understand what is the anatomical landmarks. Remember that the spinal cord is going to end anywhere between L1 and L2 in adults, and in babies, who I have to think of, it's going to be a slightly lower. Either way, you're going to be palpating the iliac crest and then identifying the LP site, typically between the L4 and L5 region. Now, what you're going to do is you're going to slowly insert that spinal needle, and you are going to go through the dura into the subdural space. Then you're going to go through the subarachnoid space, and that's where you're going to collect the CSF, and you're going to send that for CSF interpretation. So when is lumbar puncture the next best step in management? This is kind of reverse engineering some of the vignettes. So essentially, the answer is get a lumbar puncture. What is going to be the indications for a lumbar puncture? So one of the indications is going to be infection. In your physical exam, they're going to have neck stiffness. In the vitals, they're going to have fever. You're also going to be thinking about this in Guillain-Barré syndrome. Another one, multiple sclerosis. These are more demyelinating conditions. Malignancies, you're also going to be getting a lumbar puncture, but you want to get a CT head first to rule out increased ICP. Because if you get a lumbar puncture and the patient has high intracranial pressure, you run the risk of herniation. And then finally, subarachnoid hemorrhage. And this is a very important question that you need to know. And that subarachnoid hemorrhage, that's a thunderclap headache. And you will initially get a head CT non-contrast to see the blood tracking in the sulci and gyri. However, if the patient is going to have a delayed presentation, let's say 6 hours after their initial thunderclap headache, the CT scan may be negative. But if your index of suspicion is going to be high and the CT scan doesn't show any increase in intracranial pressure, you may actually want to consider doing an LP. And if you see RBCs or xanthochromia with your CSF interpretation and the patient's symptoms aligned, you're going to be thinking about subarachnoid hemorrhage. So I'm going to be just giving you the illness scripts or vignettes related to Guillain-Barré and multiple sclerosis. In Guillain-Barré, it's typically a subacute tempo, ascending numbness, tingling, with 1+ or hyporeflexia, 1+ patellar reflexes in a patient who had a prodrome of upper respiratory tract symptoms or a prodrome of bloody diarrhea. Now, in MS, this is going to be a vignette where you're going to be thinking of chronic intermittent paroxysm of optic symptoms, like, for example, INO or optic neuritis, and focal neurological deficits in a young female. I usually don't use age as one of the key drivers for my diagnoses. However, in MS, that's a little bit of an exception for me. And if I see a young female with focal neurological deficits, I am putting MS pretty high as I'm breaking down the vignette. All right. So let's go ahead and do a quick pathophysiology breakdown of this diagnosis. Here, you have an infection trigger, a humoral antibody response that causes a destruction of Schwann cells, and axonal degeneration of peripheral motor and sensory fibers. What's the diagnosis that captures this pathophysiology? Go ahead and type that into the chat. Excellent, Rija. Yoshida, very nice. Excellent. This is going to be Guillain-Barré syndrome. Great job, everybody. And understand that you can actually put management right here as well as diagnostics. So, for example, in Guillain-Barré, you want to reduce the antibody or autoimmune burden. And so you're going to be doing plasmapheresis or giving IVIG. Other things you want to note is the fact that patients who are going to have Guillain-Barré are going to have albuminocytologic dissociation. What does that mean? Well, that means that these patients, because of the humoral antibody response, are going to have elevated protein levels in the CSF, however, a normal cell count, indicating it's not infection. And that's why it's dissociation of albumino and the cytology in the CSF for patients with Guillain-Barré. All right, very good. Let's go ahead and go through this very high yield step 2 vignette. A 22-year-old female with history of multiple sclerosis controlled on natalizumab presents with blurry vision and right leg weakness. Blurry vision. Nope, blurry vision. She is noted to have an afferent pupillary light defect in the left eye. What is the next best step in treatment? Go ahead and type your answer into the chat box. Wonderful. If you are saying steroid therapy, you're absolutely correct. And the reason why I put this question in is for us to understand this very important test taking framework. And that is whenever you think about a flare of a disease, let's say that it's a autoimmune flare in this condition or a inflammatory flare, let's say in a COPD exacerbation, usually to decrease that inflammation, you're going to do a pulse of steroids. And if that doesn't work, then you're going to consider plasmapheresis. Similar in Guillain-Barré, you take bad antibodies that are attacking the neurons out and then put good plasma in. So just to do a quick little compare and contrast with MS and Guillain-Barré. MS, it's going to be destruction of the oligodendrocytes that myelinate the CNS. This is going to be a patient who primarily has upper motor neuron signs, and the most common presentation that you get in vignettes is this relapsing and remitting, i.e. the flares. Now, diagnostics that you're going to be thinking of are periventricular plaques, and this shows up in the vignette as T2 hyperintense lesions on MRI. You also will have oligoclonal IgG banding. And what this basically means is that there's an autoimmune attack with a single IgG antibody, i.e. a single clone, and that is attacking the oligodendrocytes and causing the demyelination. You're going to think of IV steroids. You're going to be thinking about interferon therapy, primarily as more maintenance medications. Other maintenance medication, natalizumab, This is going to be an alpha-4 integrin inhibitor, not particularly high yield in terms of mechanism of action, but essentially what that does is that is going to paralyze any sort of lymphocytic infiltration into the CNS. Glitterimer, this is kind of a unique mechanism that's relatively not understood, but essentially what glitterimer does is it is going to be a decoy of myelin basic protein. And so it kind of tricks the immune system to start attacking that medication and not the normal oligodendrocytes. Guillain-Barré, this is a destruction of Schwann cells. Remember, they myelinate the peripheral nervous system. These patients are going to have ascending muscle weakness with very high yield depressed Achilles and patellar. And these patients may even have like Horner syndrome like or hypotension, some sort of autonomic dysfunction with facial flushing. This is also a variant of Guillain-Barré that's very high yield for us to know. And recognize that the key here is to look at nerve conduction studies if the diagnosis is unclear, and you'll see decreased nerve conduction because the oligodendrocytes are going to not be working, or excuse me, the Schwann cells are not going to be working, and you're going to have reduced saltatory conduction, and you're going to look at the high protein in the CSF, but normal WBC count. And we have covered this as albuminocytologic dissociation. Excellent. We're going to pivot into one of our final 3 vignettes. Here is going to be the first one. A middle-aged man presents with subacute headaches, vomiting, and low-grade fever. He has a history of positive alcohol use and recently was released from prison. So social history has a high risk factors. Exam notes ophthalmoplegia and neck stiffness. The CT scan is negative, indicating no increase in ICP. Which of the following CSF findings would support tuberculous meningitis? This is an arrow question. Go ahead and type that into the chat. All right. Very good. Many of you are saying low glucose, high protein, and a lymphocytic predominance, and you're absolutely correct. Now, let's just understand this. One of the key content points that I want to let you know is that tuberculosis meningitis is the one that gives you the lowest amount of glucose. Watch for populations that are at high risk, social or immunocompromised or traveling. And the lymphocytic predominance is going to stratify this from bacterial meningitis, which typically has a neutrophilic predominance. So here is going to be a table that is going to capture normal CSF. And then what we're going to do is we're going to predict what are the various diagnoses. All right, here we go. When it comes to this answer choice, A, where you have high WBCs, low glucose, and a neutrophilic predominance, what are you going to be thinking of in this situation? Go ahead and type that into the chat. Absolutely. You're going to be thinking of bacterial meningitis. What about this one? A WBC count that is 100 to 500 in the CSF, lymphocytic predominance, you're going to have a low glucose, and you are going to have mildly elevated protein, 100 to 500. That's going to be tuberculosis. And remember that tuberculosis meningitis has low glucose, high yield. And one of the gross pathologies that you want to be aware of is that tuberculosis actually affects the basilar portion of the brain. And that's why sometimes patients can have cranial nerve deficits because it affects the area right next to the brainstem. All right, here's the next one. Elevated WBC count with the lymphocytic predominance. You're going to have normal glucose and a slightly elevated protein. Good. This is going to be viral encephalitis. This is extremely high yield. And what you want to note is that altered mental status is typically going to be the key clue that tells us, hey, this is a viral encephalitis. Another key high yield vignette that comes up, viral encephalitis, and then a MRI or CT that shows temporal lobe enhancement. And in this situation, you're going to be thinking about HSV. All right, here's going to be the last one. WBCs are normal, glucose is normal, and protein is going to be elevated. What do you think is going to be the best answer here? Yeah, if you're saying Guillain-Barré or some sort of autoimmune, you are absolutely correct. Now, in this situation right here, when you're initially seeing this table, okay, you're going to start really trying to memorize the numbers. But remember what we started with? I said quantitative to qualitative. So you can start learning this table initially as a first layer by saying, okay, I have elevated white blood cells. I have a low glucose. Turn the numbers into qualitative data points first, and then link the specific numbers. Okay, just a little learning point. All right. So in many of these cases of bacterial meningitis, we are going to use ceftriaxone and vancomycin. Now, this is a common question I ask on rounds, and that is that, hey, why do we use vancomycin? And many students actually say for meningitis, they say, oh, well, that's to cover MRSA. And when you're thinking about acute bacterial meningitis, using vancomycin for coverage of MRSA is usually going to be the right thought process if you're thinking about the patient having a shunt or a recent brain surgery. But the reason why we use ceftriaxone and vancomycin is to really tackle resistant strep pneumo. Remember that strep pneumo is one of the notorious organisms, along with H. influenza B and Neisseria, that is going to cause us to have meningitis, typically in the young adult to elderly population. And ceftriaxone is a third-generation cephalosporin that is going to have good blood-brain barrier penetration. It is going to be a beta-lactam, similar to a penicillin, and it is going to inhibit the penicillin binding protein, which is an enzyme that is going to be important in cross-linking of the peptidoglycan layer that makes up the cell wall of a gram-positive organism like strep pneumo. However, sometimes there are strep pneumo strains that are resistant or have a mutation to the penicillin binding protein. And as a result, you want to hit that strep pneumo with another mechanism, and that is where vancomycin comes in. Remember, vancomycin is going to be a medication that is going to inhibit the D-ALA bonds of the peptidoglycan, and that's why we use high-dose ceftriaxone and vancomycin together for the treatment of bacterial meningitis. All right, this is going to be one of our last vignettes. Let's go ahead and lean into this question. A 32-year-old female with HIV presents with excruciating headaches for 1 week. She is febrile. There's no neck stiffness, and there is bilateral papilledema. The CT scan is negative. A lumbar puncture is performed. What is the likely diagnosis? Go ahead and type into the chat. What do you think is the likely diagnosis here? Wonderful. If you're saying Cryptococcus meningitis, you're absolutely correct. One of the key things to always stratify in your social histories is, are you dealing, especially with infectious disease questions, what kind of host are you dealing with? Immunocompetent or compromised? In this case, it's compromised, and we see cryptococcal meningoencephalitis with the very key India ink stain that is going to show these soap bubble-like lesions, okay? Now, in cryptococcal meningitis, just like how I said, tuberculous meningitis, low glucose. Well, in cryptococcal meningitis, the key thing to associate is high opening pressure. That's very important. In fact, some patients in terms of management get serial lumbar punctures to relieve the very high pressure that cryptococcus is going to cause. Now, in Cryptococcus meningitis, you're going to have a low glucose and high protein, and you're going to have a mononuclear infiltrate in your CSF analysis. What is the next best step in management? Well, you're going to initiate amphotericin therapy as well as flucytosine therapy. And these patients eventually will need maintenance therapy for a prolonged period of time, and that is going to be thanks to fluconazole. So, what are the key things for us to know? Well, you're going to see the encapsulated yeast via the India ink stain. Sometimes questions can allude to the Saburad agar that the Cryptococcus is going to grow in. And the most specific thing to add or send for the diagnosis is going to be a cryptococcal antigen analysis. All right. So one of the mental schemas that I want to provide to you is what is the differential for high opening pressure? Besides Cryptococcus, go ahead and type into the chat. What else can cause elevated opening pressure on your CSF or lumbar puncture? Excellent. Many of you are saying some sort of subarachnoid hemorrhage, bacterial meningitis. Absolutely. So subarachnoid hemorrhage, very key, that can cause high opening pressure. Brain tumors can cause you to have high opening pressure. And I put an asterisk there. Remember, you want to get a CT scan of the head, or in a neonate, you want to get a head ultrasound to make sure you don't have increased ICP. The other thing that is going to cause you to have a elevated opening pressure is going to be IIH. This is going to be called idiopathic intracranial hypertension. It also is known as pseudotumor cerebri. This is going to be a female who has subacute headaches. Maybe she's also on vitamin A derivatives for her acne treatment. She's going to be obese, and she's going to have vision, blurry vision, and the high headache. And subsequently, she'll feel better after doing an LP that is going to be characteristic of having a high opening pressure and this diagnosis of IIH. The management of IIH, get fluid off of the CSF or the CNS region. So acetazolamide, that's going to inhibit the ventricles from making a lot of CSF. You can divert the CSF using a VP shunt. And if the patient has blurry vision and is diagnosed with idiopathic intracranial hypertension with a high opening pressure, you may have to get your ophthalmologist involved to do an optic nerve sheath fenestration. Another key diagnosis that can cause elevated opening pressure is going to be meningitis. And we've kind of covered the ancillary analyses that you're going to perform if you're worried about meningitis in your vignette. I wanted to juxtapose something called normal pressure hydrocephalus. Now, again, normal pressure. It's not an elevated opening pressure. Normal pressure hydrocephalus, that's your wet, wobbly, and wacky. And I would encourage you to take a pause and say, how do they say wet in a vignette? How do they say wobbly in a vignette? How do they say wacky in a vignette? Because once you understand how they are going to write it in a vignette and in which building block of the vignette you need to look for those symptoms, that is going to help you conceptualize and recognize NPH much faster on exam day. These patients are going to have very large ventricles. Because it's normal pressure, you're going to have no real sulcal enlargement on your imaging. And you can actually do a CSF tap test where the patient with wet, wobbly, wacky, you're going to do a LP, you're going to see a normal opening pressure, and their gait is going to be improved. And that's one of the indications that, hey, you may want to do a VP shunt in this female with normal pressure hydrocephalus. So with that, we're going to end our webinar today. I am going to be just going through this very high yield rapid review slide, and then we will be done. I would like for you guys to stick around for some announcements as well, and we will go ahead and finish off with this slide. Are you guys ready to finish this thing off? Good? Everybody good? Excellent. Thank you, Abhinav. Thank you guys for your energy. Let's go ahead and finish off. So patient presents with headache symptoms. We have a gram-negative diplococci that is going to be seen on CSF analysis. The patient acutely becomes hypotensive. What are we dealing with here? Well, remember, gram-negative diplococci, Neisseria meningitidis, and that is related to Waterhouse-Friderichsen syndrome. If you have hypotension and signs of acute adrenal insufficiency or shock, you need to give back mineralocorticoids with IV hydrocortisone. And with Neisseria meningitis, you need to do chemoprophylaxis with rifampin or ciprofloxacin to the roommate, for example. What if you have fever, altered mental status, a rash, low platelets or thrombocytopenia, and hyponatremia in a camper? A lumbar puncture is performed. What is the antibiotic that you would use? Go ahead and type that into the chat. Excellent. If you're worried about a tick-borne encephalitis, you're absolutely correct. Remember, usually these patients are going to have camping in the social history, rash, and hyponatremia, and you're typically going to use doxycycline. You're going to be worried about Rocky Mountain spotted fever, as well as even Lyme disease. All right, HIV positive patient who is seen for recurrent LPs to relieve high ICPs, i.e. cryptococcal meningitis. What is the maintenance therapy? And that is going to be fluconazole. And remember, fluconazole is for maintenance, amphotericin is for acute treatment. Fever and altered mental status in an elderly male. The CSF shows elevated protein, a lymphocytosis, and xanthochromia. What is the treatment here? Go ahead and type that into the chat. And if you're saying fever, altered mental status, and xanthochromia, yeah, HSV encephalitis, add acyclovir. And remember, the CT or MRI can show temporal lobe enhancement. Here we have a patient who had a thunderclap headache indicating potential subarachnoid hemorrhage. The CT is negative, but my index of suspicion is still high for a subarachnoid hemorrhage. You're going to do a lumbar puncture. A young male with recurrent STDs who presents with stroke-like symptoms and a lumbar puncture that notes lymphocytic pleocytosis. What else would you send in the CSF to complete your workup? Excellent. If you're thinking about neurosyphilis, you're absolutely correct. And that is where you're going to send a VDRL for your diagnosis. All right, last question here. Sexually active female who presents with acute fever and nausea, has flank tenderness, nitrites, leukoesterase positive on the UA. Treatment here, just as a little space repetition. Yep, exactly. Ceftriaxone treatment for both pyelonephritis, and if the patient has bacterial meningitis in another vignette, you're also going to use ceftriaxone. I just wanted to really emphasize the use of ceftriaxone in both of those pathologies. With that, we are done. Thank you guys so much. I would encourage you to just stick around for a couple minutes. I really appreciate your guys' time today. Today, we reviewed how if you see lower urinary tract infections or symptoms, get a UA. If you see headache, altered mental status, neck stiffness, plus or minus fever, get CSF analysis. You know how to interpret them now for your vignettes. And so with that, I encourage you all, if you have not yet, to sign up for my Step 2 rapid review. Again, a lot of new additions. I'm just going to be really building on this course, and it's a succinct review. I mean, Step 2 dedicated, it's a beast. You have so much UWorld, so many CMS forms to go through. I just wanted to get something that is a bam, quick content review if you're going to be close to studying for your comp, CBSE, even if you're in your shelf preparation, it's all integrated like how we have here today. And I do have a Notion UWorld notes template that can help you stay systematic and organized as you break down the greater than 4,000 questions that are in UWorld for shelf and Step 2 CK. With that, I would love if you can just write a very positive or honest review for me today. If you guys have enjoyed my resources, my YouTube channel, anything, share it with your friends. I would be so grateful. And I did place a quick review link. I'd love to highlight you as a student. I'm also going to be choosing somebody who attended this webinar to send a mug, my HyGuru coffee mug too. So if you are interested in that, kindly write a review and I will be announcing the winner soon. I really appreciate you guys taking the time. I'll see you guys in the next webinar. Before you leave today, go ahead and actively recall one thing that changed you as a learner. Go ahead and type that in and we will end today's session. Type in one thing that you learned in this webinar that you didn't know in the past hour and a half, and now you do. Wonderful. Quantitative to qualitative end organ dysfunction. Reason to include vancomycin. How to approach the labs. Cryptomeningitis. Looking at the UA from a clinical standpoint. AKI. Wet wobbly wacky. SIADH and DI. Very good. Excellent. Acute tubular necrosis. Very nice. Couple more. Acute interstitial nephritis. Wonderful. All right. With that, I am going to end today. I'll stick around for just a couple minutes for any questions, but let me go ahead and stop the live stream that is going on right now.